I apologize. It's not that I'm not looking at you guys. I just moved to a new office, so my camera and my presentation screen are on different monitors, so I'm not staring off into space. All right, so thanks for inviting me to talk about management of acute pancreatitis. I'm one of the advanced endoscopy attendings over at Mount Sinai Hospital, and we certainly get asked to evaluate and take care of a lot of patients with all varieties of pancreatitis, from sort of standard interstitial pancreatitis to really horrible necrotizing pancreatitis. My goal today is to kind of go over some of the sort of major elements of the management of pancreatitis, maybe introduce you all to some of the sort of latest treatments that we offer patients endoscopically in necrotizing disease, and of course, sort of field any questions you might have. I'm going to try to put some questions out there as well. So, like to encourage any sort of participation, so I can keep an eye on the chat box or just unmute yourself. The presentation is divided into like 4 or 5 different case presentations. These are all patients that I have seen and patients that we see sort of commonly. So it should give you a little bit of a flavor of the types of things that come up that I think you should all be versed in. So there's a 35-year-old male nurse presented to the emergency room with 8 hours of nausea, vomiting, and mild upper abdominal pain. Relatively acute onset of symptoms last night, multiple bouts of vomiting all night long, denies diarrhea. The pain at this point is fairly manageable, but it's just uncomfortable from just vomiting so much overnight. He denies any fevers or jaundice, and the pain does not radiate. In the ED is a febrile, blood pressure of 110/60, heart rate of 95, mild abdominal tenderness. The lab show a lipase of 95, and the lab we're in, the upper limit of normal is 70, and the LFTs are normal. Ultrasound shows cholelithiasis and a normal common bile duct. Ultimately, after being in the ER for about 12 hours, was able to be discharged with antiemetics, and then was discharged to follow up with me for further evaluation and management of pancreatitis. So what was the cause of her symptoms? Did she have pancreatitis? Did she have biliary colic? What next? Any thoughts out there from Zoom world? Anybody think the patient has pancreatitis?
I don't think this is like clear cut if it's pancreatitis. I mean, an elevated lipase alone definitely can't, well, that elevated lipase 95 doesn't seem too significant, and without like other imaging, we can't for sure say if there's pancreatitis.
Great, and you're sort of getting towards maybe diagnostic criteria for pancreatitis. Now, I'm not a big let's memorize criteria, let's memorize scores kind of person, but something about this is ringing funny for you. And what is it? What kind of criteria are you looking for to call somebody as pancreatitis? And anybody else can feel free to answer. So the definition of pancreatitis is you need to have 2 out of 3 criteria. You need a serum amylase or lipase. Typically speaking, we use lipase now, just amylase is a little non-specific. Has to be over 3 times the upper limit of normal. There are plenty of non-specific things that give you what I would say are cheap elevations of lipase. So this patient had a lipase of 90, which is barely above the upper limit of normal. So that's kind of no man's land. It's kind of like, I'm not so impressed. What else do you got? You need to have, the other criteria is typical symptoms: epigastric pain, acute, severe, persistent radiating to the back. One of the things I love about GI in general is that you can get a lot of information on history, right? We do scopes, we do scans, whatever, but history is really important. I feel really old saying that, but it's true. Patients will tell you, this patient tells us she's vomiting, and pain's like, okay. Pancreatitis is usually a lot of pain right to the, often to the back, not always, but really severe pain. The third criteria is imaging findings. So on this CAT scan here, you'll see this is the pancreas in the middle, sitting on top of the splenic vein. And there's all this sort of hazy stranding all around the pancreas. And that's a typical imaging finding for pancreatitis. You need 2 out of 3, all right? If you've got a lipase and you've got the right history, the right pain, you're done. You don't need a CAT scan despite what the ER is gonna do, okay? So the imaging is great here if you're missing something. the pain's kind of funky, or maybe the lipase is a little too low. Okay, that's where imaging comes into play. The CT scan can help you out. I've seen patients with ridiculously high lipase, typical pain, and a normal CAT scan. That's fine. You only need 2 out of 3. The degree of enzyme elevation does not correlate with severity. Once you hit the 3-fold threshold, you're done. I don't care if you're 12,000 or if you're 420. It's all the same. It doesn't really correlate with severity. And the key here, which is I think relevant in this patient, watch out for amylase and lipase elevations that are unrelated to pancreatitis. So if you have patients with elevated amylase or lipase, if you've got symptoms and you've got pancreatic type symptoms, pain radiating to the back, pain worse with PO, okay, well, maybe that is pancreatitis, right? You've got lipasemia and you've got the typical symptoms. It could be pancreatitis. It could be pancreatic cancer. So maybe the lipase isn't all the way up. Maybe it's 150, but you got the typical pain. You might be thinking of something like pancreatic cancer. But what if your symptoms are non-specific? Like in this patient, nausea, vomiting, right? That's some kind of illness. It's some abdominal or systemic disease just from being sick, from just puking all night long, having some weird inflammation of your stomach or your small intestine. You could have a colitis can do this to you. You can have a gastroenteritis. Any number of non-specific GI things can give you cheap amylase and lipase. Why? I don't think we have a great reason. No lab test is perfect. That's the reason why we have these thresholds, to get rid of that non-specific noise. If the patient doesn't have symptoms and has these high amylase or lipase numbers, all right, could be a couple of possibilities, right? Maybe they have some kind of pancreatic ductal stricture. Now we're getting to like funky stuff that I don't think you need to worry about as medicine residents. Maybe they've had an ERCP. Most patients after ERCP will have an asymptomatic lipase elevation. They could have drug-related issues. We have seen plenty of patients who are on either investigational drugs or approved drugs that have asymptomatic lipase levels. Other systemic diseases, key here is they don't have symptoms, so they can't have pancreatitis anyway, or they shouldn't. So large differential for patients who've got amylase and lipase elevations that are not pancreatitis. So just keep that in mind and keep these criteria in mind. That's really critical here. So how do we classify pancreatitis? Again, I'm not one to sort of memorize and preach certain criteria, but just try to think about these things conceptually. The phase of pancreatitis, they do define it into an early and a late phase. I'm less interested in that. The type of pancreatitis is relevant. So most of the pancreatitis that you see, that is considered interstitial pancreatitis, garden variety, ordinary, everyday pancreatitis. Inflammation of the pancreas, you haven't killed off any pancreas at all, it's just inflamed. Necrotizing pancreatitis, the presence of necrosis, means you either have dead pancreas or some dead tissue around the pancreas. It has a very typical imaging finding and tends to portend a worse course. Now, severity is relevant here, and this is the one thing that is important to know. When we think about severity, it has nothing to do with pain. It has nothing to do with lab abnormalities. It all has to do with organ failure, all right? And organ failure is defined as either hypoxia, hypotension, or acute kidney injury. And I'll show you some numbers in a second. If you have no organ failure at all, doesn't matter how bad your scan looks, doesn't matter how much pain they're in, this is mild pancreatitis. If you've got organ failure that persists more than 48 hours, this is severe pancreatitis. So we're defining the severity based on the systemic sequelae, the systemic response to pancreatitis. So as I mentioned, interstitial pancreatitis, 90% of pancreatitis is in this bucket. 20% of pancreatitis, even though it's interstitial, is more than mild, moderate or severe. You might get a pseudocyst, which you have heard about, we'll talk more about. Relatively low mortality, 2%. Necrotizing pancreatitis, inflammation with necrosis with dead tissue. This is 10% of acute pancreatitis, so it's a real number. Usually they're moderate or severe, may lead to walled-off necrosis. Pseudocyst is a blister of fluid. Walled-off necrosis is a blister with dead tissue inside of it. And the mortality is much higher here, 20%. So this is a typical scan of interstitial pancreatitis. You can see the pancreas here, and here that gray haziness all around it. This is necrotizing pancreatitis. This is where the pancreas is supposed to be. You see this gray sort of amorphous blob. That's dead tissue. The pancreas should be enhancing. There's IV contrast here. You should see the parenchyma. Parenchyma is gone. That is dead pancreas. And that's generally not a good thing. So we talked about severity for a moment. Mild is no organ failure. Organ failure less than 48 hours is moderate, and severe is more than 48 hours. Hypoxia, hypotension, elevated creatinine. They hit the door and they're hypotensive, they've got organ failure right away. If it goes away with some fluids and 12 hours later, okay, not the worst thing in the world. It does put them in that moderate category. But if they're sort of persistently hypotensive and hypoxic and so on, that's that severe category. And then the mild group, and this is one retrospective study, just looking at the criteria, 0% mortality. The moderate group, 3% mortality. And look at the length of stay. It goes from 3 to 8 days. Severe, 26% mortality. Length of stay is a little bit longer, but the ICU stays, much greater percentage. So the patients who come into the ER who are hypoxic and hypotensive, you should be worried about them. They might look okay, but their numbers are telling you otherwise. And this is all the systemic response to pancreatitis. BUN predicts mortality. So if you think old school and Ranson's criteria, they talk a lot about hematocrit. And the idea there is hematocrit. If you have a high hematocrit, that reflects hemoconcentration. You're under fluid resuscitated, you're concentrated. But, you know, this is a retrospective study of, I think, 6,000 patients. And you can see the patients whose hemoglobin kind of, there's no real dividing line between the non-survivors and the survivors, right? Everyone's hemoglobin sort of trended down. It didn't really differentiate that hemoconcentration as measured by hemoglobin. But by BUN, you see a different story. And those patients where the BUN improved over 48 hours, they tend to survive. Those whose BUN goes up, those patients have a higher likelihood of death. In another study, they basically looked at patients, they looked at BUN and hematocrit. And there's a million scores out there for pancreatitis. There's BISAP and Apache and a whole bunch of like number scores, and I hate all of them because one, I can never remember them, and two, they don't really predict a whole lot. BU and hematocrit predict a ton. If you take hematocrit and divide it into 5 quintiles, the people in the higher quintiles have a higher rate of predicting organ failure and necrosis. If you look at BUN, the higher quintiles of BUN, again, higher rates of predicting organ failure and necrosis. So, you know, but an odds ratio of 3 to 5, something like that. But it's relevant. It's an easy thing to do. You're in the ER, you see the patient, their BUN is 45. That is not good, right? That should already warn you they're having a lot of hemodynamic changes related to their pancreatitis. So to slice it again, if you were to stratify outcomes by hematocrit and BUN, high hematocrit, yes. A rise in BUN in 24 hours, 54% of them are going to have organ failure. If the BUN goes down in 24 hours, okay, organ failure rates drop. What if the hematocrit comes in, they're already on the low side, right? They don't seem as concentrated up front. And now you split by BUN. That rising BUN, again, high rates of organ failure, low, like decreasing BUNs, lowest rates of organ failure. Right? All of this speaks to the importance of their sort of fluid status. So the second case, 36-year-old male presents to an ED with severe abdominal pain radiating to the back. Sudden onset 12 hours ago, mild associated nausea, no history of alcohol use. Afebrile heart rate of 90, blood pressure of 110/60, BUN of 12, creatinine 7. We like those numbers. Hematocrit of 42, lipase of 5,400. LFTs are normal. The ultrasound is pending. So what are you going to do for the guy? What's your first step in management for him? Fluids. Excellent. Now, for all the stuff we've come to understand about pancreatitis, it just comes down to IV fluids. We haven't had anything miraculous in the last 15 years about pancreatitis, but we do have a little bit of an understanding. So there's a little bit of a cascade of inflammation and ischemia. You've got acinar cell injury, right? This is what pancreatitis is. The acinar cells are injured, and you're getting leakage of enzymes everywhere, and that's auto-digesting other tissues and so on. So that releases cytokines, not surprising. Then you get to this inflammatory state. You've got sort of the humors of inflammation running around. And then once you get into that inflammatory state with all those sort of inflammatory cytokines, the local capillaries become more permeable. You might start to get some vasospasm, start leaking fluid out. And now you might get some very local level pancreatic hypoperfusion, right? As this is happening down at the capillary level, the pancreas is going to kind of get a second hit, right? You got the acinar cells already being injured from all these enzymes that are activated. Now you're going to get a little ischemic injury. So a little local ischemia leads to more cytokine release, and you end up in this sort of spiral, but that also ultimately leads you to SIRS, right? Whatever starts out happening in the pancreas now is cycling, perpetuating on itself, and now you get a systemic response. And that SIRS is what leads to organ failure, right? And this is sort of your traditional sepsis physiology. Okay, so what could IV fluids do? Well, if you give someone IV fluids, maybe you could prevent the pancreatic hypoperfusion, and then you prevent the local ischemia and prevent the cytokine release, SIRS, and organ failure. And that's kind of nice. You might be able to block the cascade. So there's some data to show that early resuscitation improves outcomes. Another retrospective study. And they divided patients into two groups. The early group got more than a third of their fluid in the first 24 hours, right? And the late group just got their fluid just sort of given to them throughout. Well, the early group, patients who got a lot more of that fluid up front, much lower rate of SIRS compared to the late group who might have just gotten sort of maintenance IV fluids all the way through. Shorter length of stay between the two groups. Sort of interesting. Another thing that has come up is lactated ringers versus normal saline. So this trial was actually initially intended to randomize people to sort of aggressive IV fluids versus standard of care. This is in 2011. By around this time, there's already enough buzz about more fluids that the aggressive group and the standard of care group ended up being the same, right? Because everyone's like, we'll give IV fluids, this is new. And everyone got IV fluids. And so they really weren't able to assess in this study this aggressive versus non-aggressive resuscitation. But they did add another variable in here, and lactated ringers for normal saline. Now, do you guys end up using LR or normal saline? What do you guys tend to use for pancreatitis? All right, I see an LR up there. Good. Well, the reason LR works, if you see here in this group, in the LR group, the rate of SIRS from admission into 24 hours later drops dramatically, where there's no change in the normal saline group. And if you look at CRP levels, the LR group is much lower than the normal saline group. So lower SIRS, lower rates of acidosis, decreased CRP. Normal saline is really acidic. It has a pH of 5. So it's interesting because in medicine, forever and ever and ever, we've always just pounded normal saline, like for anything. And anesthesiologists and surgeons have been a lot smarter, and they preferred more physiologic fluids like LR, or now they do like Normasol and a whole bunch of other random sort of complex fluids with lots of other buffering agents and things in them. And as medicine, we were like, you guys are morons, normal saline's all you need, but they actually were right in that you do need that buffering ability. That neutral pH is actually a big deal. And so when you give people all of this normal saline, I think you're creating more tissue level acidosis. And there's multiple studies that show you clearly have lower rates of SIRS with LR. And so it seems like you guys are already doing that and you sort of stick with that. It's fairly well supported in data. So the problem with the IV fluid story is the clinical trials are kind of mixed. This is probably one of the few better designed ones. This trial was actually spearheaded by a medicine resident I think it was UCLA, who really took it on herself to really like drive forward this trial taking off, because the key here is randomizing standard hydration to aggressive hydration, and you got to do it in the ER. You can't wait for 12 hours for them to be on the floor. And so I think sort of like a high lipase level hit, she got paged, ran to the ER, randomized patients. And I only say this because it doesn't have to be a whole team of sort of like GI fellows and research coordinators. This was a resident, and they took non-severe acute pancreatitis, randomized to 20 mils per kilogram bolus followed by 3 mLs an hour versus a 10 milligram per kilogram bolus and 1.5 milliliters per kilogram per hour. And then they sort of had goals at 12 hours. If the BUN and hematocrit were going up, another bolus. Otherwise, or you got bolused and got moved up to a higher rate. And you'll sort of see they define improvement as pain, improvement in pain, hematocrit, BUN, creatinine, and tolerance of PO. So overall, that aggressive group had higher rates of improvement than the standard group. And you can sort of see an improvement in 36 hours, development of SIRS, lower rates in the aggressive group, persistent SIRS, lower rates in the aggressive group as well. This has been a very hard thing to study because of what it takes to randomize people when they hit the door. So a lot of studies that are out there, the randomization happened later. So there's a bunch of studies actually where there was no improvement within the aggressive IV fluids group. There are some studies that show the aggressive IV fluids group actually do worse because you've kind of flooded them too much. And I think it really comes down to how rigorous study and how good are we at getting fluids up front. The pathophysiology for how it works, I think makes good sense. It counters the microvascular changes, reduces the acidosis. The data is conflicted. The higher quality studies with pertinent endpoints do seem to show an improvement. So the evidence really suggests better outcomes. So I say 1 to 2 liter bolus in the ER. You know, you can do the sort of weight-based 3 mLs per kg per hour. I would sort of say 200 to 400 mLs per hour of LR, for 24 hours, and then reduce to maintenance. The key, as I see a lot of patients, they're still having pain after 24 hours, so they still keep up that rate of 250, 300 mLs an hour. It has nothing to do with pain. It's all of those circulatory changes that happens in the first 24 hours. So you've got to dial them back. You'll see patients, they're like, I can't stop peeing. I'm up all night peeing. And I'm like, why are you on this much fluid 4 days in? You don't need to. You can go to maintenance. It's the first 24 hours where it has an impact. But we can't be blind. Follow the respiratory status, follow the urine output, follow their BUN, and use these things to adjust your fluids accordingly. If their output's brisk and their BUN and heart rate are down, but they're starting to get some fluid overload and some shortness of breath, okay, you need to dial back. And so you have to be actively thinking about it. After that, the question in the chat is how long do you want them on maintenance fluids till they're taking PO and are able to maintain themselves. And so if they're eating like great PO on day 2, okay, you don't need IV fluids anymore. Case 3, 28-year-old female with idiopathic recurrent acute pancreatitis. She's on our service now in the hospital here. Readmitted elsewhere about 2 weeks ago with recurrent pancreatitis, had her typical pain and elevated lipase. Ongoing pain despite NPO and TPN. Imaging with inflammatory changes around her pancreas consistent with pancreatitis. No pseudocystic fluid collection, normal white count, afebrile, normal LFTs. What's next? What can we do for her? Ongoing pain, 2 weeks in. Nothing intervenable on imaging. So the key here is that we had this patient comes to us on TPN. So we have to ask ourselves, what's the role of TPN here? So in my fun with PowerPoint animations, here's our GI tract. We take fat, protein, and carbs, right? Goes down to the duodenum. We stimulate CCK and secretin. That stimulates the pancreas. You get bile. You get all the enzymes coming out of your pancreas. You get bicarb, lipase, and so on. Well, that converts all those fats, proteins, and carbs to mixed micelles, oligosaccharides, amino acids, and these float on down into your distal duodenum and jejunum where you get absorption. Great, normal digestion. Now, if you give someone an NJ tube, a nasojejunal tube, a tube that goes all the way down here to the jejunum, you never stimulate CCK, you never stimulate secretin. The stimulus for those two hormones comes from food being in the stomach and in the duodenum. So if you bypass all of that, maybe you can shut your pancreas down. And that's the idea. So this study was from 17 years ago, and it's hard to believe anybody consented to this study. What they did is they measured basal rates of trypsin by putting in an NG or a tube through the nose down into the duodenum. And they just suctioned up all the trypsin that's being made. And that reflects your activity of the pancreas. So you take normal people and say, hey, have an NG tube, let me know how this goes. And you determine their trypsin rate. And then you put these patients on like IV fluids or TPN even. And on TPN, you find that their pancreatic activity is actually a little bit higher than fasting. So, okay, fine. What if you give through a nasoduodenal tube polymeric feeds? These are basically like, any standard osmolite or Gevity, a standard enteral feed. You get a lot of trypsin activity. Your pancreas is really active. And you say, all right, well, let me give you food that's already broken down, something like Peptamen or Vital, where everything is already, hydrolyzed, an elemental formula. A little less activity than the regular nutrition. But now let's give you a jejunal feeding tube, 60 centimeters distal to the ligament of Treitz. And you'll see that the trypsin rate is the same as someone who's fasting. So when you give somebody nutrition down in the jejunum, you really suppress pancreatic activity. Why is this relevant in pancreatitis? So when you've got pancreatitis, all of these elements start to take over. You get some dysmotility from inflammation. You get some increased gut permeability from allostasis. You get bacterial overgrowth. And then there's translocation from the GI tract into other spaces. So when you give someone enteral nutrition, you prevent the dysmotility because you keep things moving along. That in turn prevents the bacterial overgrowth. So you don't have extra numbers of bacteria in the small bowel. And it also prevents the gut from being permeable because you're trying to use the gut on a regular basis. So in the end, this decreases bacterial translocation tremendously. And so in 7 randomized trials of nasojejunal feeds versus TPN, huge reductions in the mortality, huge reductions in the mortality in severe pancreatitis, decreased rates of multi-organ failure, and decreased rates of systemic infection. The studies clearly show the superiority of NJ feed. And you don't actually need nutritional support unless they're going to be NPO for more than 5 days. So most patients don't need this. So in our patient that I described up there, within 36 hours of starting nasojejunal feeds, her pain is gone. And she's been in-house for a week on jejunal feeds and is now tolerating oral intake and is about ready to be discharged. And that's it, and we see this time and time again, that you can really shut down their pancreatic activity and patients do feel better. There are ongoing trials of nasogastric feeds versus nasojejunal feeds. There's some theory that NG feeds may work just as well because maybe the pancreas isn't responding so well to that stimuli. That's pending. We do try NG feeds in some patients because placing an NJ tube is kind of annoying. And I'll let you torment, your GI fellows with doing that. But it works, and it's important, and it's something to really think about, and definitely do not have them on TPN. Starting an oral diet, so more towards the patients you all tend to see, is the patients who come in with interstitial pancreatitis, get better in a few days. What do you want to feed them with? Any thoughts? What do you guys tend to give your patients? What's the first diet? Go ahead.
Liquid diet, right?
Sure, it could be liquids. Any other thoughts? Do most people kind of start with liquids and move on up? What are other things that people do? Someone says low fat. Someone says go right to regular. And when do you decide to feed them?
As soon as they're able to eat.
Yeah. So if they're hungry, essentially. So I love this table. This is an aggregate of a bunch of different nutritional studies on pancreatitis. They looked at different elements. What to give patients as their first diet. There are trials on full liquid diets, on light diets, on enteral feeds, or a standard clear liquid, full liquid, low fat, whatever kind of diet. They looked at variables of who decides. Does the patient decide or does the medical team decide? I looked at when to feed, looking at everything from predefined schedules of 36 hours, now you start eating, to sort of more objective evidence of like lipase levels, or subjective cues like hunger. In the end, there's sort of an evolving consensus. Patient focused, first of all. Nothing objective here. Start the diet early when the patient is hungry. When they're like, I want to eat. They may want to eat before their pain is gone. For many years, I used to wait till their pain was gone, thinking, okay, if they still have pain and they eat, they're just going to get worse. They will self-regulate. Length of stay has been shown to drop by a day with this kind of algorithm, right? And if you think about going from 5 days to 4 days, hospital administrators are like drooling at their seats thinking about this, right? But that's a big deal. It's a whole extra day you can give a patient back in their life. So start the diet early when the patient says they want to try something. They're not going to hurt themselves. They will self-regulate. You can skip the clear liquid diet phase. I've done the clear liquid diet for years. But when you think about it, pancreatitis has nothing to do with consistency of food. Gastroenteritis does, right? If you had a gastroenteritis, you're not going to go out for steak and fries right away. You might want to try out some water and maybe some Gatorade. So consistency is actually irrelevant. Full liquid diet, when you think about it, is the worst because it's all cream of something, right? That is not going to help you with high fat stuff. Pathophysiologically, low fat makes the most sense, right? Fat is one of the most potent stimuli of the pancreas. So maybe steak and fries isn't so great, but a cut of lean chicken, fantastic. Rice, sure, why not? Alfredo sauce, not a good idea. But what's been funny is the last 5 years is patients are like, I'm eating healthy, but they're having avocados, which are super high fat, and they're eating nuts. And I've had patients with pancreatitis who swear up and down they're eating all like really healthy stuff, and they feel like just because they avoid hamburgers, they're okay. But the fat from an avocado stimulates your pancreas just as much as the fat from a double cheeseburger. So low fat in all senses of the word. So just start them on a low fat or regular diet. I would say low fat physiologically makes sense. Objective data has no bearing. It's at least not inferior to the traditional, like, wait till you have no pain, start you on clear liquids. Seems like there's a decreased length of stay. I think more and more med students, residents are now getting taught to get them onto a diet sooner. But I'll tell you right now, really push this. Don't force your patients. They'll self-regulate. But if you can have them tolerate a reasonable little bit of low-fat diet, some liquids, you could get them out of the hospital much faster. Next case, 33-year-old female admitted with 8 hours of severe pain radiating to the back. History of severe, significant alcohol use, never had similar episodes before. Temperature of 101.5, heart rate of 110, blood pressure of 80 over 40. Sick, right? Clearly has got some of those severe pancreatitis, organ failure things we've talked about. Labs, white count of 22, LFTs are normal, creatinine BUN of 20. CT with significant stranding around the pancreatic body and tail, no necrosis, normal biliary tree. What's next? What do we make of this? High white count, febrile, little hypotensive. What would you like to do? Give her antibiotics, go to the OR for some kind of debridement.
IV fluids.
IV fluids. Great. This is similar to a patient that was in our system somewhere. This patient ultimately went to the OR, tragically, because they were like, oh, infected, stranding, went for some kind of horrible debridement, and has been sort of a hospitalized mess ever since. And now our team has finally gotten involved, or GI is now finally involved, and we're trying to manage her more correctly. But how do you explain the fever and the hypotension?
Well,
Thoughts?
the hypotension would be part of the organ failure that we were talking earlier.
She could also
The fever and white. Oh, go ahead, Raj.
no, go ahead, finish. I'm sorry.
Yeah, and Omar, I guess some part of like the fever and the white count could be like inflammatory. It doesn't necessarily need to be infection, right?
Yes, absolutely important. 100% spot on. Pancreatitis is a sterile process at first. So when they get admitted, they should be febrile or they could be febrile. This is an incredibly potent inflammatory process. So fevers and white count, totally normal. Hypotension, also not uncommon. It's all part of the severity of SIRS. So all of these things make you think of infection and make you think of sepsis, right? And with good reason, you see plenty of this in other diseases in your training. But it's not. In this case, it is SIRS. And you need to know that pancreatitis is just inflammation of the pancreas. Up front, there's nothing bacterial or infected about that. That is a sterile process to start. And it's hard. You're going to have to stick to your guns and be like, no antibiotics. This is not infected because it isn't infected. That's just the way pancreatitis is. Look, if they have high LFTs, you could argue maybe it's cholangitis. Very reasonable. No one would ever fault you, and people probably would encourage you to sort of give them antibiotics. But in this situation here, without any obvious other source, it's SIRS, and it's all inflammatory. The necrotizing pancreatitis, even prophylactic antibiotics, was something that was debated forever. People got imipenem forever for necrotizing pancreatitis. A bunch of studies have been done over the years, and there's no effect on mortality, rates of infected necrosis, rates of other infections, rates of surgical infections, or rates of fungemia. So don't do it. Don't throw antibiotics on patients early on in their course of antibiotics when they do not have any evidence of infection. So you never need it in mild acute pancreatitis. It's sterile. The translocation of gut bacteria, which we talked about earlier with the enteral nutrition stuff, that happens later. And that's 7 to 14 days later. So someone comes with pancreatitis and they're initially febrile, the high white count, cool, no problem. 7, 8, 9, 10 days later, they're still having fevers, or they defervesce and now have new fevers. Now they're infected. Now an open season on translocation, totally different ballgame. So you have to keep in mind that time course. That's why we talk about that early and late phase of pancreatitis, because the pathophysiology changes. Prophylactic antibiotics, higher rates of infections with resistant organisms, and fungemia. So if anything, it'll hurt the patient if you just start using all these broad spectrum antibiotics up front. So that's just important to recognize. And a lot of times when I talk to our fellows, we go around, I'm like, we try to pull all these patients with pancreatitis off antibiotics because everyone gets nervous. But if you remember the physiology of the disease, early phase pancreatitis is totally sterile and purely inflammatory. A little sidebar on gallstone pancreatitis. The way this disease occurs, stones in the gallbladder, stone jumps out of the gallbladder down to the bile duct. That stone has to come all the way down to the ampulla in order for you to have gallstone pancreatitis. Because the idea is that stone gets stuck there and sends a wave of pressure up the pancreatic duct. This diagram is a little bit wrong. It makes it seem like the stones kind of roll into the pancreatic duct. They don't. They come down to the ampulla and they kind of pass along the way. So it's not the big, huge stone that causes pancreatitis. A big, huge stone doesn't make it out of the gallbladder. May not make it down the bile duct, certainly isn't going to make it down to the ampulla. It's the big, huge stone's friends, the little tiny guys. Tiny little stones will come down, hit the ampulla, and pass on through, and you'll never find them. Most patients with gallstone pancreatitis, you'll never find the stone that did it. By the time they hit the ER, that stone is long gone, right? Because it's the tiniest stones that come down here and send that wave of pressure into the pancreas. So how do you know if they have gallstone pancreatitis? For years, I went around thinking, even early on in my career as an attending, it's only gallstone pancreatitis when you've got clear signs of biliary obstruction. jaundice, high alk phos, only then can you say it's gallstone pancreatitis. Everyone else, you're on a hunt. That's kind of wrong as you think about the fact that it's those tiniest little stones. In this study, in this meta-analysis, ALT over 150 had 96% specificity. And if you look at all the other individual LFTs, you can see patients with a normal bilirubin 14% of the time, normal ALT and AST 12% of the time, and all four LFTs normal 10% of the time, and they have gallstone pancreatitis. So 10% of all gallstone panc have normal LFTs. Most have some abnormalities. You don't need to see significant cholestasis like you might see with a big stone in the bile duct. All you might see is a little ALT of 52, a cheap alk phos of 145 that goes away quickly. Any of those things that are there, very suggestive, almost clearly proving that there's gallstone pancreatitis. In fact, if you don't have any cause at all, no alcohol, no drugs or anything else, and they have gallstones, you might as well consider that the etiology. And it's even easier to really say that if they have any abnormal LFTs on admission. So I see a patient who gets sent for what's billed as idiopathic pancreatitis. But I will look back at all their admissions for pancreatitis, they have a cheap ALT every time that normalizes. So they probably passed a tiny something, triggered pancreatitis, and they never were able to find the stone. You do a cholecystectomy of those patients and they're good. When should you do a cholecystectomy? So this is a pretty impressive RCT from 2015, has now been replicated a few times since then. They looked at patients came in with gallstone pancreatitis, and they randomized them to getting a cholecystectomy on that admission or waiting 30 days. And for all of you who've tried to get your surgeons to take them to the OR on that admission, it sometimes can be hard to beg them to do this. Well, what they looked at is mortality or readmission for any gallstone complications. If you waited 30 days, 17% of them either died or had gallstone complications. Cholecystitis, recurrent pancreatitis, recurrent choledocholithiasis. 5% had those complications had they gotten their cholecystectomy on that admission. So the surgery was the same in terms of its difficulty. 51% of patients in that group that waited 30 days reported biliary colic of some sort, recurrent colicky pain while they waited for the cholecystectomy. So the fact is that when one stone is jumped down into the biliary tree and caused pancreatitis, you are very likely to have other stones jump in the future and in a very short period of time. So get those gallbladders out on that admission. There's a lot of surgical stuff, like a lot of coordination that has to occur, and not all services are built for this. But we've all seen a lot of patients who go home to go see their surgeon as an outpatient, come back 2 weeks later with pancreatitis. And so the key is try not to let that happen. Get that gallbladder out. There's great level 1 RCT data supporting this practice. This comes up often. People ask us, they've got gallstone pancreatitis, go do an ERCP. The only time you need to do an ERCP is if they have cholangitis. A little bit hard to figure out with the fever thing, but if you've got like rising LFTs and fevers, okay, fine. Cholangitis. If you see a stone on imaging, or they've got ongoing biliary obstruction, I put a little question mark, meaning hard to assess that. Generally, the practice has gone to a conservative strategy. MRCP if you have a low suspicion of them still having stones. What do I mean by low suspicion? They came in, had high LFTs, had pancreatitis. Each subsequent day, LFTs came down, they're improving. Doubtful there's still a stone stuck there. They're doing well. Get an MRI. Prove that they're doing well, and then go say, hey, surgeon, go take out the gallbladder. If there is some suspicion, okay, fine. If you've got persistent jaundice, persistent pain and high LFTs, we'll do an endoscopic ultrasound to look. It's more accurate than an MRI, or we'll go right to ERCP. But long and short of it is the pancreatitis 99% of the time is going to get better whether or not you take that stone out right away. In 13 years now, I don't think I've done an ERCP in the acute setting of gallstone pancreatitis. 1 or 2 patients over the years have had simultaneous cholangitis. They needed it. And everyone else, their pancreatitis just gets better. So you don't need to rush in to do this. So no role, and this is now supported with a couple of clinical trials recently, no role for ERCP in gallstone pain. Questions so far? All right, in the last handful of minutes, go ahead.
Sorry.
No, go ahead.
I have a question regarding the feeding of the patient. Because I think we see it often on floors. They start in PO, and then you're hesitant to when to start the diet. And then I had a patient, we started like advancing diet. I didn't know about the no liquid, but we started advancing, but he continued to have pain, and we saw it as a sign of like worsening. So we just put the patient in PO again, and it's just like an ongoing thing, like very subjective. And then my second question is, when would you consider the NJ2?
Yep. So it is very subjective, and that's okay. If their eating is causing them more pain, then you do have to pull back. You will find that doesn't happen very often. And many people get burned by those small number of patients that get worse when you feed them, and they have said, okay, we just shouldn't feed anybody. Most people do fine. They self-regulate. They don't let themselves eat very much. And then you make them NPO again. Give them a couple more days and then try again. And if at that point they're just failing 5-6 days of this, then I'll go ahead and go for an NJ2. It suppresses their pancreas a lot, and then they end up turning the corner quite a bit faster. But what you did is right. Most patients won't get pain. Most patients say, it didn't feel great, I stopped. And then you just, let them self-regulate. Be like, okay, they might nibble for a few days, and then they'll start to recover and feel better and go on. But they're not going to hurt themselves. This next bit, not going to get too into the weeds of this. The term pseudocyst is a little old, and the nomenclature has evolved, but they're sort of clunky words. A pseudocyst, we all know, and that involves from an acute fluid collection. What does that mean? Pancreatitis, it's like a big fire. Whole pancreas is up in flames. If you were to ever burn yourself, everything, your hand's on fire, then you get a blister. That's a pseudocyst, right? It's a wall around this inflammatory fluid. So this here on CAT scan is a pseudocyst. This is a wall around simple looking fluid. It's a result of interstitial pancreatitis, right? No dead tissue, just inflammatory stuff. So you start out as pancreatitis, you get acute fluid collections, these early shapeless inflammatory balls, and then it becomes a nice big wall. And the contents are very homogeneous, so this is a typical pseudocyst. Walled-off necrosis is the other term. This is the newer term. So walled-off necrosis, or WON, neither of which roll off the tongue very happily. Now you've got someone with necrotizing pancreatitis, and that dead tissue gets encapsulated. Now you get walled-off necrosis. And you can tell this is perfectly smooth and homogeneous. This has some different densities of stuff in here and all around. That suggests solid stuff inside. And that solid stuff is that dead tissue. So when do you intervene? Pancreatic fluid collection, pseudocyst or the walled-off necrosis. If they're infected, if the collections have gotten so big they're obstructing the stomach or the duodenum, if these collections are irritating the pancreas and causing recurrent pancreatitis. These collections are big and cause mass effect and cause biliary obstruction. Or they just have ongoing pain from the presence of a big, huge thing. In necrotizing pancreatitis, and here, certainly in our hospital, these patients probably 20 years ago all were on the surgical service. And as GI became more adept at managing this stuff, we've pulled them all onto the medicine service, much to the tragic work of our house staff, because these patients are super sick. But they no longer, surgeons were happy to give us these patients because they weren't doing well under surgery. And so we intervene in those patients if there is persistent unwellness. You go in every morning, you're like, you don't look good. And then the next morning, you're like, you still don't look good. Persistent unwellness. If there's any proven infection in the scan or persistent organ failure for many weeks. And so on scan, we saw earlier that homogeneous thing with the little weird densities. All this air in the fluid, that all suggests gas-producing organisms and essentially almost like an abscess. Same thing here. This almost looks like stool, but what it is all that solid debris with infected stuff all For time's sake, I'll talk a little bit about where our data is with this. There was some in the Netherlands, they have this incredible pancreatitis network. You basically call 1-800-pancreatitis and you get thrown into these ridiculous RCTs. But these RCTs have changed how we approach pancreatitis. They randomized people with necrotizing pancreatitis to drains, followed by a minimally invasive quasi-laparoscopic procedure for debridement of all this dead stuff. Or they went for like open surgery, old school, open the abdomen, scoop all the stuff out, go to the SICU with an open abdomen, go back in a few days later and keep scooping stuff out. The mortality in the open surgical group is 70%. And even in the minimally invasive group, it's 40%. Endoscopically, this is what we can do. This is a pseudocyst that we see under endoscopic ultrasound. This is a needle that we put into the cyst. We're going through the stomach wall. This is the stomach wall. And in this case here, we're sort of dilating up this tract. We've made a hole through the stomach wall into the pseudocyst, and now this river of pus starts flowing as we open that up. Patients here used to go to IR for drains or go to the OR. Endoscopic, we've done this, and this may take us 15 minutes now. And then we put in some stents to kind of drain it. In walled-off necrosis, under endoscopic ultrasound, scope in the stomach, we see this debris in this fluid cavity. Here's our needle coming across. And then we place the stent that connects the cyst to the stomach, similar to what the surgeons used to do when they used to suture the cyst to the stomach. And now we take our scope and we actually go into the cavity itself. And this is all dead tissue in this cavity in the retroperitoneum. And we literally take different tools and just scoop out dead stuff, all done through a hole we make in the stomach. And we come back week after week and clean out dead stuff. And we're just pulling out, that's a cast of a pancreas that we pulled out like through the mouth. And then after a lot of work, you can see that this looks relatively clean. There's no dead stuff in here. And this cavity closes down. So when we take this endoscopic approach and compare it to the minimally invasive surgical approach, high rates of death and major complications still. This is a very morbid disease. Lower rates of fistulas, length of stay, 35 days in the endoscopic group, which is still super long, but compared to 65 days in the minimally invasive group. So does this work? Here is a patient transferred to us from upstate with horrible necrotizing pancreatitis. You see all the inflammation everywhere. He was here for 6-8 weeks, persistently febrile for 3 weeks, in the ICU forever. But after a lot of work, all of that inflammatory dead stuff is gone. A couple of stents left, and 7-8 weeks after coming here, left the hospital back to sort of being a normal 25-year-old. So it does work, and they do well. Final thoughts: pancreatitis is common, local inflammation with systemic sequelae, multimodality strategy, early aggressive IV fluids, preferably LR, early reintroduction to oral diet, enterals, feeds if you need any nutritional support, more than 5 days NPO, no empiric antibiotics, same admission cholecystectomy and gallstone panc, no need for an ERCP. And then pancreatic necrosis, it's a multidisciplinary management, step-up therapy, endoscopic stuff, work with IR, and some patients need surgery. But it's a team approach there. And that's it. Any questions for me?
Thank you so much, Dr. Nagula. And yes, if there are any questions, you can write them in the chat as well.